Hello and welcome to my celebrity wellness evaluation presentation. I am Keyshawn Purtle. I am currently a master's student at Touro University, and this wellness presentation is for our disease prevention class. Let's get into the meat and potatoes and introduce our celebrity. I chose to do my presentation on Kevin Hart. He was born July 6, 1979. He is an African American stand up comic, actor, and producer. Born and raised in Philadelphia, Pennsylvania, he was well known for his hilarious stand up comedies and box office hits such as Laugh at My Pain and Central Intelligence, which co starred Dwayne "The Rock" Johnson. He has three children: Heavenly Hart, Hendrix Hart, and Kenzo Cash Hart. His first two children are with his former wife, Teray Hart, and his third child was with his current wife, Aniko Hart. He has been married to Aniko for since August 13th, and they have one child together. He was previously married to Teray Hart, and they have two children together. Dive into our subjective information. So we're going to go over his history of present illness. This also includes his age and demographics. Kevin Hart is a 39-year-old African-American male, present to clinic today with a complaint of burning pain when he urinates and the feeling of urgency, and he needs to urinate often. He states that he has a consistent 7 out of 10 pain in his supra pelvic region, so suprapubic region, and he gets a burning pain when he voids that started 2 days ago. Kevin states there is no aggravating or relieving factors to his current discomfort, and Kevin also states that his urine looks dark and cloudy with a sour-smelling odor. Patient is sexually active with his same partner, his wife of 3 years. He denies fever, nausea, vomiting, headache, numbness, or tingling, shortness of breath, dyspnea, flank pain, blood in urine, any penile discharge, or penile or scrotum irritation, and denies chest pain also. Patient states that he has no history of STIs or any GU issues. History. Patient was diagnosed with hypertension and around 2012, and it's still active. His surgical history. Patient stated that he had liposuction performed on his abdomen and belly area so he can receive a six-pack abs in 2015, and no other surgical history is endorsed. Kevin's current medications or supplements, he actually takes a multivitamin once daily, and he is on lisinopril 20 milligrams by mouth daily for his diagnosis of hypertension in 2012. Allergies, he stated he doesn't have any known allergies as of right now. He's a star. He's married. He states that he feels safe at home and denies any physical or emotional abuse. He is a tobacco smoker. He says he smokes half a pack a day of cigarettes. Being that he actually is in the entertainment industry, he states that he drinks socially, 2 to 3 drinks socially, but he socializes a lot. So, looking into alcohol abuse would be something we'll do in the anticipated. Recreational drugs, the patient states that he does not use recreational drugs for IV use. Sexual history, he is heterosexual with his current partner. No history of sexually transmitted infections, and does not use condoms with his wife. He states that he uses spermicide and lubricant. Spiritual, patient states that he does not have any spiritual conflicts as of now. Nutrition, he reports no change in his appetite or eating. Exercise, he does exercise vigorously, 60 to 90 minutes in the gym daily. He stated it's to maintain his figure for public appearance. He's currently employed, self-employed as a comedian, actor, and producer, and he is booked, overbooked basically. So he does get constant work. And he says his sleep, he usually gets 7 to 8 hours of sleep when he can, nightly, or if he's actually on a club appearance, he's states that he just shows for the 30 minutes and then goes home and goes to sleep with his family. Family history, patient's mother is 64 years of age, is living with hypertension, and the patient's father is 67 years of age, living with a history of hyperlipidemia. States that he is up to date with his immunization due to his high school requirements. He does take the annual flu vaccine during a flu season, and his last administration of Tdap was 12 years ago. So we'll look into offering him the Tdap, especially since he travels out of the country a lot to do stand-up and also acting. All right, let's get into his review of systems. Currently, his general, he states no fever, chills, denies night sweats, reports no trouble getting to sleep. His hair and nails, no changes in hair or nails, denies itching, jaundice, bruising, or dilated veins. His ENT, he denies headache or dizziness, denies changes in vision or blurry vision, no hearing loss or earaches, no nosebleeds, no sore throat or hoarseness, and denies dysphagia or TMJ pain. Neck, he denies any pain, stiffness, or masses. Respiratory, he denies coughing, wheezing, and also denies shortness of breath. Cardiovascular and peripheral vascular, he denies tenderness or pressure around the chest, walls, arms, or shoulders. Denies chest pain or palpation. Gastrointestinal and abdomen, he denies any indigestion, nausea, vomiting, diarrhea, constipation, gas, bloating. As far as his urinary, he does have a complaint of the urinary frequency, urinary urgency, and dysuria for the 2 days. He denies any changes in starting stream of urine, strength of urine stream, dribbling, denies blood upon urination. He denies penile discharge, penile rash or scrotal rash, or abdominal pain. He only endorses the suprapubic pain or discomfort towards his bladder area. Musculoskeletal, he denies muscle aches and spasms, stiffness, swelling, and joint pain. His neurological system or nervous system, he denies any tingling or sensational changes. No changes in attention span or speech pattern. Denies fainting, incontinence, saddle anesthesia, or bilateral lower extremity weakness. As far as his psychiatric, he denies any depression, agitation, or increased confusion. He denies suicidal or homicidal ideations and reports a slight disturbance in sleep due to the frequency of voiding. Into his gender-related health care. Due to the patient's age, he's 39 years of age, so a cholesterol screening is recommended for men aged 20 to 35. He stated his was done 5 years ago, so when he was 34, and his cholesterol was in normal range. His last HIV and STD screening was completed 1 year ago, and the patient also performs random testicular self-exams for testicular cancer to try to catch it early if it occurs. Moving along, we're going to get into our objective information and objective findings. Patient's vital signs, his weight, he's 137 pounds. Height, he's 5'4". BMI is 22.2, so within normal range. Blood pressure is 129/73. Sitting on his left arm, that's where it was taken. His pulse rate is 86 regular rate and rhythm. His respirations are 15 unlabored. SpO2 97% on room air, and his temperature is 36.9 degrees Celsius, taken orally, and he currently endorses a 7 out of 10 pain. This is also a physical exam, wellness exam. I did a comprehensive physical exam with the patient, so basically a head to toe. His general survey, he's a 39-year-old African-American male, well-groomed, dressed appropriate for the weather. Patient is alert, awake, and oriented, responsive, and cooperative. It appears to be in no acute distress. His head is normal cephalic and atraumatic, without any tenderness, visible or palpable mass, depressions, or scarring. Hair is of normal texture and evenly distributed. Eyes, his visual acuity is intact. Conjunctiva are clear without exudate or hemorrhage. Sclera is so basically doesn't have jaundice. Extraocular range of motions are intact. His pupils are equal, reactive, and round, and to light and accommodate. His fundi appears normal, including optic discs and vessels. No signs of a nystagmus. Nose, no discharge. Nasal mucosa is pink. The nasal septum is midline. Nares are patent bilaterally. Throat, mouth, no tonsillar swelling, tonsillar exudate. Oral mucosa is pink and moist with good dentation. Tongues normal in appearance without lesions and with good symmetrical movement. No buccal nodules or lesions are noted. The pharynx is normal in appearance. No adenopathy noted. His skin is pink, dry, and warm. No suspicious moles, rash, open wounds, lesions, or bruising, or petechiae. Lymphatic system, no obvious masses. Lymph nodes, non-tender and mobile. Thorax and lungs. His thorax symmetrical with full expansion of 1 to 3 centimeters. Lungs are resonant. Diaphragmatic excursion is 3 to 5 centimeters. Breath sounds are clear, A and P, just anterior and posterior. No cough, wheezing, no rales or rhonchi. Cardiovascular, his rhythm, he's in a regular rate and rhythm. No jugular vein distension. No heaves, thrills, or palpitations noted. Point of maximal impulse palpated at the mid-clavicular line in the fifth intercostal space. Has crisp S1 and S2 sounds. The S1 is greater than the S2. Tricuspid and mitral. And the S1 is equal to S2 at Erb's point. S2 is greater than S1 in the pulmonic and aortic. No S3 or S4, no murmurs, clicks, or rubs. As peripheral vascular, there's no varicose veins, scars, or lesions of the extremities. No pallor or cyanosis. No difference in temperature of the lower extremities compared to the upper extremities. Capillary refill is less than 3 seconds. Pulses are 2 plus equal bilaterally in the brachial, radial, femoral, popliteal, and posterior tibial and dorsalis pedis. Aortic pulsation felt to the left of the midline epigastrum, and it's 3 to 4 centimeters wide. No aortic bruit heard. In his abdomen, he does have tenderness guarding towards his suprapubic area. Abdomen symmetrical and protruding with active bowel sounds in all quadrants. No bruit, venous hum, or friction rub noted. No CVA tenderness noted. No tenderness to percussions in any of the 4 quadrants. Liver span is 6 to 12 centimeters. Edge is smooth and palpable, 1 centimeter below the right costal margin. Abdominal is soft, non-tender in other regions. No palpable masses or hepatosplenomegaly. No rebound tenderness. Abdominal aorta palpated and less than 3 centimeters. Spleen is non-palpable. Musculoskeletal. Neck and spine have no noted deformities or signs of inflammation. Curvature of the cervical, thoracic, and lumbar spine are within normal limits. Bony features of the shoulders and hips are of equal height bilaterally. Posture is upright and gait is smooth and normal. Spinous process of C7 to L3 palpable, midline, and non-tender with no step-offs. Upper extremities. His DTRs are 2 plus, pulses 2 plus, skin's warm, dry, intact, muscle tone and strength are 5 plus, and sensation is intact. Lower extremities, his DTR is 2 plus, pulses 2 plus, Skin is warm, dry, and intact. Muscle tone and strength are 5+. Sensation intact. Murray's circumduction test negative. No lower extremity shortening bilaterally. No knee joint deformity bilaterally. Range of motion, flexion, extension, and rotation of the spinal column. The upper extremity and lower extremity are unremarkable. Due to the patient's nature of complaint, I did place labs, which will be a in-clinic dipstick urine analysis, and this patient was positive for nitrates and leukocytes. And leukocyte esters was positive also. So now we get into our what we diagnosed the patient with, and then also differential diagnosis. My diagnosis was, his first medical diagnosis was UTI. Reason I chose this is because this condition is an infection that occurs in the kidney, bladder, or urethra. In most cases, the UTI, which is caused by infecting a bacterial infection in the bladder, the patient may present with dysuria, urinary frequency, blood in the urine, which is hematuria, flank pain, CVA tenderness, and urgency. And this patient actually endorses urgency, burning pain when he urinates, and tenderness in the suprapubic region. And also with the UTI, the urine dipstick would be positive for nitrates or leukocytes, or leukocyte esterase. I'm sorry. So therefore, the medical diagnosis of urinary tract infection was reached. And then also his second medical diagnosis, because it's been diagnosed previously and it's still active, it's his essential hypertension. Currently, you can tell that it's being managed well and under control because his current blood pressure was 129/73. The patient does work out vigorously 60 to 90 minutes a day. And also he does take medications, which you can tell that they're working because of the current blood pressure. So with this, you just basically continue to monitor and ask the patient about any side effects that that the medicines may occur. So and this patient, he endorsed no complaints or complications with his current chronic condition, and then or adverse effects of the medication regimen. So therefore, we'll continue to keep him on his current regimen, which I'll get to later on. Now, differential diagnosis of his current complaint, which is the pain and urination. I would actually go with sexually transmitted infection. Rationale for this is because a lot of times, I'm not going to say a lot of the times, but some of the times, especially when you're a sexually active adult and he's a celebrity, so basically he's active in the social life. Pathogens such as gonorrhea, syphilis, or chlamydia can occur, and it's also very important to screen your patient for STIs. But this patient, he denies penile discharge and or itching in the groin area or irritation. So therefore, we just rule out the STI, and also will be confirmed with lab tests performed outpatient. So later on in my plan of care, I'm more than likely going to send them out for labs just to, be sure, because it's always important to try and find out that it's negative than to not try or not investigate and actually find out later on that it was positive. So it's always good to investigate and find out, oh, well, good, you're actually negative, instead of not doing it and find out later on, because early prevention or early detection is very important in STI. And my second differential diagnosis was non-infectious urethritis, which is inflammation of the urethra caused by irritants such as spermicidal products, and it can cause pain on urination. The symptoms of this condition is burning and pain on urination. The patient does complain of burning pain when voiding, and so therefore this diagnosis will be used if after you do the urine dipstick analysis, if it was negative for the nitrite and leukocyte esterase. But in this case, the patient was positive for the nitrates and leukocyte esterase, so therefore we were able to rule out this diagnosis. Ta-da, we're almost done. Plan of care. Pharmacological treatment of urinary tract infection. Guidelines state macrobid antibiotic is actually a great starting point to make sure that the patient's symptoms are actually resolved. And in this case, we'll start off with 100 milligrams, 1 tab, PO, 2 times a day for the UTI. The duration of taking this medicine is 5 days. And the cost of the average supply, a 5-day supply, which would be 10 tablets, is $15.20 on average, which I got from GoodRx. Education for this medication that you will want to inform the patient is common reactions to this medication may include nausea, vomiting, anorexia, abdominal pain, diarrhea, flatulence, vertigo, nystagmus, dizziness, headache, drowsiness, alopecia, yellow or brown urine. So you want to make sure to inform the patient that because as they're seeing their urine a different color, it may actually alarm them. Fever or rash, pruritus, which itching, urticaria. If your patient actually has urticaria, you want to inform them to actually stop taking this medicine, because that's obviously a hypersensitivity reaction. And arthralgia and rigors. So with arthralgia, that's basically joint pain, and you want to make sure that if the patient is endorsing any of these medications, you want to make sure any of these complications, you want to make sure to inform the patient to give you a call or give your office a call or go to the emergency room and to stop taking the medications for the things such as the rash or itchiness and the urticaria, and then also the vertigo and the nystagmus and dizziness, because those are signs that basically the medication is affecting the patient's day-to-day active daily situation. So you don't want the patient to and then also like a hypersensitivity, you don't want it to progress into anaphylaxis. So you want the patient to be aware that to not power through if you're getting into those adverse effects that are more dangerous and life-threatening. So he's currently still on lisinopril due to his previous diagnosis of hypertension. And so that case, basically a refill of the 20 milligrams of lisinopril, one tablet per day for hypertension. Duration is 30 days, and normally in this case, you actually give them 90 days worth, because for hypertension, once it's controlled, you will more than likely set up a follow-up appointment with the patient in 3 months to get new labs to make sure that his renal function is not being disturbed, and also that the patient is tolerating the medicines and does not actually endorse any adverse effect. So education for this patient, the cost of the medication average is $4 for 30 tablets, 30-day supply, and I got that from GoodRx. Education, make sure to let the patient know that this medication may cause dizziness due to it lowering the blood pressure. It can cause hyperkalemia and also increase urination, because it's basically making them void. It's affecting the angiotensin and renin complex. So therefore, a lot of the water or the fluids are actually going to be voided. And then, so in this education also include informing the patient that when getting from coming out of bed to a standing position, tell him to take time to gain his balance, and also when coming from a sitting to standing position, may get lightheaded or dizziness, so he should actually do it in a slow fashion, or do it as he gets use or regulated on the medicine. It would actually not occur as much. Pharmacological treatment plan for the UTI. We will educate the patient on hydrating properly, so making sure that they're drinking enough water to sustain them throughout the day, especially seasonal when it's summertime, especially in Vegas. Oh my goodness, drinking a lot of water is very important. Dehydration is one of the telltale signs, and also can cause urinary tract infection. And it also helps to, when drinking water, you're going to void. So therefore, it helps when voiding to clear the urinary tract and the urethra due to the properties of the urine, and urine being acidic. It clears the urethra, which would remove bacteria out of the urethra, therefore not causing therefore helping prevent a UTI. Education on voiding after sexual activity. This is very important. As you see, the patient actually uses spermicide instead of condoms. So therefore, and then also when not using condoms or using condoms, the bacteria can actually get into the urethra, especially if you're not using condoms. The bacteria from the other person that you're getting into, from your intimate partner, can travel up the urethral canal or opening and causing a UTI. So therefore, avoiding after sexual activity is very important, especially for a male, due to the fact that we share the same orifice for ejaculating and also voiding. So this will actually help clear any extra bacteria or spermicidal products that can actually go up the urethra. And then also educating the patient on avoiding using spermicidal products due to spermicide being sometimes an irritant, and then as I stated before, with it being able to go up the urethra, it can cause irritation, inflammation, and from there, allowing bacteria to colonize and grow. Especially if you're actually using um, spermicidal products often. Hypertension, we're going to recommend the DASH diet for lowering the sodium intake to 2.4 grams daily. And also moderate aerobic physical activity 3 to 4 times a week. Patient actually already does this. He does 60 to 90 minutes, but just reinforcing it to let them know, hey, you're doing great at managing your hypertension and keep up the moderate or in his case vigorous exercise. And then also educating the patient on taking daily blood pressures just to make sure that also taking daily blood pressures is important because you don't want this patient to, especially if he's doing his activities, to take his blood pressure medications when his blood pressure is actually within a normal range. At that point, they can actually hold the medications and can just continue to monitor the blood pressure. And from there, if they're starting to see a climb, then take the blood pressure medications. But if your patient is at a 120/80, when they're taking a blood pressure or below that, you don't want them to actually still take their blood pressure medicine because therefore it will cause the blood pressure to go lower, which can cause symptoms such as lightheadedness, dizziness, and syncope. Into our non-pharmacological diagnostics, as I stated earlier, we're going to do a urine culture and analysis. Send that out to lab just in case the patient does not respond to the macrobid. We can actually have the cultures already growing to make sure we know what type of bacteria, whether gram positive or gram negative, and in that case, we can actually structure or prescribe the medications that would fit that bacteria that the bacteria has a sensitivity to make sure that his symptoms are resolved. And then also the urine dipstick was already done in clinic. The urine chlamydia and gonorrhea test sent off out clinic, and we'll basically contact the patient if labs are just to go over labs once labs come in. HIV test, just because his last one was a year ago, and he's endorsing genital issues. So while we're sending them for labs, why not get the HIV test and then also a syphilis test just to rule out the STI to make sure that the patient doesn't have STI? Because sometimes I've actually seen it in the emergency room where I currently work, where a patient has a UTI and then also they have a STI. So they'll do the urine culture and analysis and find out that the patient is positive for a UTI, and then also they'll do the urine chlamydia and gonorrhea, and about 2 days later, we have to give them a call to give them PCN for their gonorrhea infection. So it is important to make sure that you're covering all bases. And sometimes a person can have actually comorbidities, can have dual infection. So next, the non-pharmacological diagnosis for diagnostic testing for hypertension, just because he's been on it. Been diagnosed since 2012, and he's been on the medication regimen. We're going to do a renal function panel in 3 months, just to make sure that his renal function is working correctly. Because with hypertension, It can actually cause a large impact onto your kidneys. Therefore, it can cause in kidney stage chronic kidney disease. It can cause acute kidney disease, and then also some of the medications because it deals with the angiotensin and renin conversion. It can actually affect the renal function, especially if it's being excreted in the renal tubules, which majority of medications are. And then we're going to do a lipid panel in 3 months, just because he does have hypertension, and you want to actually make sure that when you have hypertension, you actually have a higher risk for heart diseases and comorbidities. So therefore, doing a lipid panel within the 3 months just to make sure that his cholesterol levels and triglycerides and HDLs and LDLs are within normal limits. And then we're going to do a comprehensive a CMP, which is comprehensive metabolic panel, just to make sure that he's not experiencing hyperkalemia while taking the medications, because that actually is something that can occur because with the medication, how it actually removes sodium, therefore potassium will go up if sodium is decreasing, if sodium is going down. So next, we're into our anticipatory guidelines. We're going to go over the primary, which was safe sex counseling, informing the patient, okay, if you're using spermicide and you want to actually, you're trying to prevent pregnancy with spermicide, you can actually use condoms because spermicide does not actually protect you for STIs. And we're going to do vitamin, mineral, and multivitamin supplement for primary prevention of the cardiovascular disease and cancer. So basically go over the multivitamins and its mineral, especially when we do the CMP, just finding out what he's, and then also because he has hypertension, just to make sure that we're ahead of the cardiovascular disease that can actually be a comorbidity of his current diagnosis, which is hypertension. Tdap vaccine, because his last Tdap was 12 years ago, and Tdap is normally updated every 10 years for a patient. Secondary, we'll do smoking cessation because the patient actually smokes half a pack a day, and it also can cause lung cancer, higher risk for COPD or pulmonary diseases, and higher risk for cardiovascular diseases. HIV screening for the patient because he's within the age of 15 to 65 and he's sexually active. So we've already set that as lab panels for him when he went for the urinary culture that we're going to send out. And so we're going to actually set him with some blood records for the HIV screening. And then also syphilis screening for sexually active adults, especially a patient that is presenting with gynecological problems or urogenital problems. Now we reached the point where we're going to speak to the patient, close out the session or the encounter by doing follow-up instructions. With that, I will inform the patient to return to clinic within 5 to 7 days for reevaluation of condition or sooner if symptoms worsen or change. If symptoms do not improve within 48 hours after treatment of the antibiotics, If he has blood in his urine, if he has penile discharge, rash, hives, itching, muscle or joint pain, and any new GU issues are not able to be, or if his symptoms are not able to be controlled by his medications. Or, of course, to go to the ER. So whichever one is easier for him to actually contact us or come in sooner for us at the clinic or go to the ER, especially for emergent things such as the hives or muscle or joint pain. So we'll also educate the patient on voiding after intercourse, send the patient to outpatient diagnostics for lab testing, and follow up with the patient with any abnormal labs. Inform the patient to take medications as prescribed. This is very important. Taking the medication, especially with the antibiotic, a lot of patients will actually start the regimen of the antibiotics, and once their symptoms have resolved, they actually stop mid treatment, and this actually can cause resistant bacteria. So therefore, this patient may create a resistant bacteria that won't respond to antibiotics like they did the last time, and then from there, it'll make it harder to treat the patient if symptoms do reoccur. And from there, we're going to educate the patient on avoiding spermicide products. Educate the patient on hydrating properly. Educate the patient that the condition that he has, which is hypertension, is chronic but is able to be controlled by lifestyle modifications and then also adherence to the medication. Educate the patient about medication side effects and to be careful rising from a sitting to standing to avoid dizziness due to the hypotension. And then also we're going to educate the patient to check his blood pressure before taking the lisinopril and to hold the pill if the blood pressure is 120 over 80 or lower. All right, this concludes. Thanks for listening, and I hope you have a wonderful day. Here are my references. Bye-bye.